And I would like to introduce you to our attendees. Dr. Vishal Vanani is a senior cardiologist from Kiran Hospital, Surat. He has more than 10 years of experience. He was trained in Jaslok Hospital under Dr. A.B. Mehta. His experience in diagnostic cardiac catheterization, coronary angiography, simple as well as complex PTCA and physiology coronary evaluation. Thank you so much, sir, for joining us.
Thank you. So,
And do we have Dr. Alok Ranjan, sir, also with us?
he is just now occupied with an emergency, so we could not have him here.
Okay, sir.
Okay, so here we have a case of 55-year-old lady who is suffering from the chest pain, heaviness, and headache for last 15 days. In the initial evaluation, she was found to have high blood pressure, which was first time diagnosed 10 days back. And she was started with antihypertensives, and the basic investigation showed normal ECG and normal 2D echocardiogram. I guess I've been informed that the viewers of these programs are a combination of physicians as well as general public in view of the World Heart Day broadcast. Is it so? So let us make it a Heart Day oriented case, kind of informative case for the public, more of than the more of technical sounding case. So a lady which he was evaluated for the chest pain, and after control of blood pressure with 10 days of medications, her treadmill stress test was done, which showed after about 7 minutes of treadmill run, she had ST depressions as well as chest pain. The depressions persisted till recovery, which is a sign of ischemic coronaries. Now, it is important to mention here that the sensitivity of treadmill stress test is 68%. That means out of 100 patients who are having actual ischemia, the treadmill comes positive in 68% of the patients. We can be wrong in 32% of patients also. Same way, the specificity is 77%. So out of 100 healthy people, if treadmill is done, 77 will show normal treadmill test, but 23 will be falsely diagnosed to have high ischemic risk on the base of TMT being positive. So our patient having treadmill positive, we have to verify the coronary blood supply. So let us start with coronary angiography. So for the general public and viewers, let us focus on how we are doing when coronary angiography is advised to you. So it is a simple procedure in today's date. Most of the centers in Western India, and I guess in the other part of India as well, are doing angiography through the hand, that is radial angiography. So radial artery, when used for angiography and stenting purpose, it is very safe, convenient, and comfortable option for a patient. In the initial good old days, all the operators were doing it through the groin, through femoral approach, but radial procedures have changed the experience and comfort of patients towards angiography. So I'll just briefly show the arterial puncture technique, where we feel the artery, we give local anesthesia on the side of the artery, we check for the arterial location or the subcutaneous location of the needle tip, then we insert anesthetic agent, that is being lignocaine, and we spread it around the artery. After that, an introducer needle, which is a radial puncture needle, it is used to puncture the artery with the counter puncture technique. So here, the anterior as well as posterior, the upper and lower wall of the artery, both are simultaneously punctured. So you can see the blood drop in the needle. After removing the central stellate, we have to withdraw the needle. And as we withdraw, we let the point of this needle come into the lumen of the radial artery with slow withdrawal, and the blood gush starts. That confirms the presence of needle tip in the radial artery. So here the arterial blood bleeding spurt is there. At that moment, we introduce a guide wire. So that makes sure that the wire is in the vessel. By giving a small nick in the skin so that the sheath gets easily inserted, we make a space, and over the wire we introduce the needle. So this is a very simple technique for radial artery puncture. After putting a sheath, we need to give arterial dilator substances, which is usually the calcium channel blocker, the nitroglycerin, and we also give heparin, because the radial arteries are prone to get occluded with the thrombotic occlusion after intervention. So even for the angiographic intervention, that is just a 10 to 15 minutes job, we need to give heparin in the radial artery. Now we are done. So we start the procedure with the Tiger catheter, that is the radial angiographic catheter. Go. So over the wire, J-tip wire, we insert the diagnostic catheter that goes inside the artery. From arm, it travels all the way up to the central arteries. एक लंबा सांस लीजिए आप, लंबा सांस लीजिए. Okay. So it reaches up to the root of the heart, and there we need to engage the tip of the catheter in the artery, and then we simply push the dye inside, and that gives the radiographic picture of the coronary arteries. Obviously, everybody has seen angioplasty cases in a series, so this is quite a basic thing, but I think it is important for the person who knows very little about the coronary's intervention. So when we insert the dye, so that is the coronary angiographic picture. So you can see that the arteries are wide open, except for the small atherosclerotic deposits in the proximal part of the left anterior descending artery. We would confirm the absence of any significant disease in all possible three-dimensional views. So we can see that the arteries are quite tortuous, but the lumen is quite normal. We have seen almost all segments on the left side for LAD, left circumflex, diagonals, and OM. All right, so that is it for the left side. Now we'll engage the catheter on the right side coronary artery. Okay. All right. So that shows that this patient has no coronary artery atherosclerotic disease severe enough to cause ischemic chest pain, that is angina chest pain. So the treadmill test proves false positive in her case, and she can be convinced that the coronary artery disease is not the cause of the pain. Now, when the coronaries are not the cause of the pain in the chest, then there are several differentials, which can be a musculoskeletal pain, a bony pain, or joint pain, peptic ulcer pain, gastritis or dyspepsia or belching. These are the differentials of having pain at the same site as the anginal pain can be. So she, having normal coronaries, now needs not to go ahead with the coronary artery intervention. For the small atherosclerotic deposits in the left ventricle descending, she will be continuing aspirin and statin both continuously on and on. Let us talk something about the World Heart Day theme this year. Now that is no heart for the heart. That means we need to know what is going on about our cardiac health. We need to know what it needs to be taken care of well, what it needs when it is ill. So these details are nowadays widely available with different platforms at different places on different medias. So the only issue is at the level of understanding and implementing, not at the level of knowledge. So on the World Heart Day, I wish all the people know about their cardiac health, especially when they are reaching the age of 35 to 40 being Indians, because this is the age when the normal cardiac health checkup should start. In the current scenario, when the cardiac diseases are getting more and more prevalent in the early ages, we need to be more vigilant. We need to check the heart and its fitness earlier by the age of 35. So I would urge all the viewers, especially those who have not got their cardiac checkup. We often advise this in the doctors group as well. When we have a forum of all doctors of different sorts of specialties, there we also have to discuss that it is not that the doctor himself or doctor themselves are very keen and very particular about their own health, because they are the most negligent person about their health. They might be treating 100 patients in a day on OPD and indoor basis, but at the end of the day, they forget to take care of their own health. That is the reason why the average age of a practicing doctor in India is 10 years less than a general person. So that is of quite concern. We need to make the doctors also aware about taking care of their own health, taking their own checkup, not to have self-diagnosis and self-treatment in those fields or those subjects which is not their specialty. This is a quite prevalent thing. A person who is a specialist as a surgeon would always treat their fever and their infection themselves. A person who is an ENT surgeon would treat their malaria fever, dengue fever. So we need to let the specialist work, get the consultation at the earliest, and follow the advice that is given by any specialist. That is not something that you do not know. This is just to remind that your health is as important as the 100 patients' health that you have treated today. So that is from our end. Thank you all for watching.
Dr. Vishal, thank you so much for joining us. We have few questions in our chat box.
Yes.
So we would like to
Please.
ask you, sir, what all are the other options than PTCA once we find the plaque in the artery?
So when the plaque extent is of less severity, when we say less severity, that means less than 70% for most of the arteries and less than 50% for the left-sided main artery. So when it is of less severity, which actually is not significant hemodynamically, which actually is not hampering the blood flow at any level of activity and any level of cardiac stress, then it requires stabilization of the plaque. It requires prevention of further increase in the severity. That is achieved with antiplatelet, aspirin or clopidogrel, then statin drug in a good dose. Statin would stabilize the plaque, prevents its progress. That is a bare minimum. Other than that, if the severity is not much, then patient needs to take care of their lifestyle, control of their blood sugar, blood pressure, stop any habit of smoking or tobacco in any form, have as much stress-free life as possible. This is all one can do when there is no significant disease. Obviously, you have asked other than angioplasty. So if angioplasty is not there, then medical management, as we have discussed. The third thing is, if the plaque is severe at many places and which is not technically feasible or beneficial to treat with the angioplasty, then comes the coronary artery bypass grafting surgery. The bypass surgery is the solution when the angioplasty is either clinically or technically not advisable, not beneficial. Other than these three options, being medical management, angioplasty, and bypass surgery, one other option is the EECP, that is external counterpulsation. Now, unfortunately, this treatment is quite wrongly taken by different sorts of patients. It is not the option when you have already angioplasty or bypass surgery possible for you to operate upon. It is given as an advice when your arteries are not possible to be treated with angioplasty or bypass in most cases. The disease is so extensive that they cannot be treated with grafts and with angioplasty and stents. Then EECP would medically give some improvement in the blood flow, open up several collaterals for circulation, and give relief from the angina, give relief in the pain, improve the exercise capacity, and in certain extent can improve the myocardial performance also. So EECP is the fourth treatment option, but in a very specifically indicated cases when the cardiologist has already advised, then only it should be carried out. But the problem is it is used as the over-the-counter treatment option, like we go to the medical store and ask for the paracetamol. It is not over-the-counter treatment. It is a specific and scientific treatment which needs to be taken when it is advised actually. So these are the treatment options other than angioplasty when the coronary artery has the disease.
Sir, can the CT angiography be used as a diagnostic tool?
A very good question. CT angiography is definitely a diagnostic test, which is an alternative to the conventional angiography, what we have just done. What is the difference? Now we should talk about the positive and negative predictive value. That means the ability of any test to give us the answer even before doing the test should be first decided. For example, if there is a 22-year-old boy who is having chest pain, and in all sense we are sure of him not having coronary artery disease, but we just need to prove it definitely by some test which is 100% sure, then the negative predictive value comes at help. If we get CT coronary angiography and it shows normal coronaries, we are done. We need not to go further. But when we have a 65-year-old male patient who is a smoker, diabetic, and who is having typical angina, who has a stress test positive, then there are all possible chances that he must have coronary artery disease. In those cases, we do not advise CT coronary angiography because when we do CT coronary angiography, we will see certain amount of disease at different segments. CT coronary angiography will give us the idea of presence of disease, but would not quantify them exactly. So it cannot give us the further treatment idea. What is the treatment required for such a particular artery cannot be derived from CT coronary angiography. So when the positive predictive value is important, then CT coronary is not advised, then conventional coronary is advised. So in short, CT coronary will give us the idea of having presence or absence of the disease. But if the disease is present, then the quantification is very gross, mild, moderate, or severe. They are not as accurate as 10, 20, 30, 40% like conventional coronary angiography. So CT coronary is advisable only when, before doing the procedure, we are sure of person not having disease. Otherwise, we do by conventional coronary only.
Okay. Thank you, Dr. Vishal. Dr. Vishal, one more question is there, and that they wanted to check that how frequent a preventive health checkup should be, an individual should get it done.
So there is no specific guideline to say at what age one should start. But according to the current scenarios in the Indian population, the age at which we are most frequently seeing different patients with coronary artery disease, I would say at the age of 35, one should have their first cardiac health checkup at the age of 35. If that is completely normal, then the second can be at the age of 40. After 40, at least every 2 years, one should have complete cardiac checkup, because after 40, within 2 years, there can be changes where the results can be different within 2 years. So, as I said, there is no specific guideline, but as per the patient's disease demography that we are seeing day in and day out, after the age of 40, every 2 years, one should have their cardiac checkup. If we find something wrong in any of the checkup, then there should be more frequent checkup as well.
So, sir, once the PTCA has been done, so what diet and type of exercise would you recommend to your patient?
After PTCA, the basic goal is to lower the cholesterol and triglyceride levels in the blood. That is the main aim of the diet modification. If the patient is hypertensive and diabetic also, then these two components would also add into the diet modification. So the basic diet modification requires low fat diet, which includes less of oil content, less of fast food, less of junk food, more of fruits and vegetables, more of omega fatty acids, fish, more of regular serving of different nuts. This should be the bare minimum in the diet that one should follow. If the patient is diabetic also, then he should follow sugar restricted diet also. If he is hypertensive, he should follow salt restricted diet also. So the basic idea of post angioplasty diet is to have our lipid levels in control, have a healthy uh, fruit and vegetable containing diet, so that the antioxidants are in a quite good amount consumed in the diet, so that atherosclerotic process gets halted or they stop.
And sir, what type of exercises would you recommend? Yoga or
So the exercise for a healthy person and exercise for a cardiac patient, these are two aspects. For a healthy person, the exercise which requires is a moderate intensity physical activity for at least 30 minutes a day. That activity can be a brisk walking, running, jogging, cycling, aerobic exercise, swimming. Any of these, as per the convenience of the person and his environment, can be practiced 30 minutes a day, at least 5 days a week. That is sufficient to burn the calories, enough to maintain their body fat composition. For a cardiac patient, the prescription of the exercise is a tailor-made. It is not one for all. Suppose there is a person with the ejection fraction of 15%, then obviously he cannot run for 30 minutes as like the normal healthy person. So for the patient with the weak heart, that is with the low ejection fraction, we advise gradually increasing physical activity, and that requires aerobic activity initially up to the level of his comfort, and then pushing a little bit 2 to 5 minutes each day, so that his endurance increases gradually. For patients with the heart disease whose heart pumping function is normal, whose ejection fraction is normal, They can exercise as a regular healthy person 30 to 40 minutes a day or 5 days a week.
Okay. Thank you, Dr. Vishal. So, Dr. Vishal, these days there are many smart watches in the market, and they generally check your heart rate. So, one person, an individual, can know what is their has heart been increased or the heartbeat is decreased. Plus, nowadays there are apps coming up with the ECG. So, do you encounter such patients who have come to you that they have come to understand whether there is an increase in the heartbeat or a decrease in the heartbeat with some abnormalities in the ECG which they have come across via these smartwatches?
Yes, this is quite prevalent nowadays, particularly when more and more companies are coming with the ECG and heart rate monitoring facility. So there are two things. One is the heart rate and the ECG. Heart rate is monitored by any device, any watch, any pulse oximeter, any mobile also. Heart rate is a very fluctuating property of the body. It cannot be fixed for a person for all time. Suppose if somebody is sitting quiet, his heart rate is 70. The moment he stands up and starts walking, his heart rate increases 90 within 5 seconds. If he starts running, it can be 100, 110. So the most confusion that is there for everybody is my heart rate is varying too much. Actually, it is normal thing because the body's requirement is served by the heart via making changes in the heart rate and blood pressure. So the change is normal in the sleeping position. When somebody is in the deep sleep, heart rate can be 45 or 50 or 55 also. And when one is running, it can go up to 150 also. So variation is normal. It is not abnormal. Second thing is ECG. ECG is provided in several watches. The most being discussed is the Apple Watch, which is introduced 3 to 4 years ago and which was approved by FDA to have ECG. Now we need to understand that it is not a complete full ECG. A complete full ECG requires 12 different leads simultaneously taken together and plotted at once to interpret. But what Apple Watch does is a single lead ECG. There are not 12 leads, it is a single lead ECG. That single lead helps in detecting atrial fibrillation, one of the arrhythmias, but that does not help in diagnosing the myocardial ischemia, myocardial infarction, heart attack, or the other arrhythmias. So watch with the ECG facility is useful only for detection of atrial fibrillation because it shows us only single lead and the heart rate and the variation in the heart rate. So for a person who is a watch owner himself, he barely diagnoses himself certain things on the basis of the data provided by the watch. But it is useful when this data is recorded, plotted, and printed and shown to a doctor, a heart specialist, then he can diagnose things and comment to the person. So a watch as such is useful to see the heart rate, in which range my heart rate is moving. But for diagnosis, the person himself is not able to diagnose anything based on the watch data.
Yeah, yeah, that was pretty informative that the ECG is only, and in the watches, it is only from the one lead. So, another question is that how have these government schemes helped poor patients in getting the treatment for coronary artery diseases? Like Ayushman Bharat and pretty specific, these schemes are specific to each and every state. Also, the state government is also doing their bit. So, we just wanted to understand your point of view, sir.
So the scheme, particularly Ayushman Bharat, which is running all across the nation, has actually helped the poor people a lot. We see day in and day out those patients with acute myocardial infarction who would otherwise die because of non-availability of the money, the treatment charges are now being saved because they are holding Ayushman cards. So these card and the scheme has helped a lot of thousands and lakhs of people to have best treatment for coronary artery diseases, if I say about cardiology particularly. This is the very big positive point of this yojana. I would say with the positive point, there are certain negatives as well. Now, on the big dimension, when it is helping the poor community, on the small dimension, they are actually harming the medical profession. Which way? Because of the Yojana, the general public has a perception that any heart disease is amenable for treatment in Yojana. But we all know that technically it is not possible for the medical management of the heart disease, for the heart failure treatment, for the cardiogenic shock treatment that we treat it in the Yojana, because they are not specifically mentioned as a part of the Yojana treatment. So there, the patient is misinformed. The patient has a misguidance that any sort of treatment is available in the Yojana. So there comes the clash between the healthcare system and the patient. That is one negative point. Second is, with the more and more prevalence of this scheme, the science is actually dying. For the science to evolve and maintain themselves, there should be a quality treatment. But because of the prevalence of the Yojana, we are seeing daily those patients who actually are not candidates for the Yojana scheme are getting treatment in the Ayushman Yojana. And there, the capping of the price, the capping of the treatment options is preventing us from using the best of science for a person. Suppose if somebody is requiring a transcatheter aortic valve treatment, because of the Yojana, he needs to go for the high risk surgical aortic valve replacement because that is free in the scheme. Suppose a person who is having a severely calcific coronary artery disease, who would otherwise be treated with the intravascular lithotripsy and stenting, is going for coronary artery bypass surgery because of the free treatment being available in the scheme, but not the IVL being available. So in a way, in a small amount, it kills this science. So the big picture is it is beneficial for the needy people, but also the same way, the different side is it is killing science.
Thank you, Dr. Vishal. Thank you so much for all the details that you have provided. So the last question will be, what message will you like to give to your patients and our attendees on a World Heart Day?
So I would like to give two messages. One is know your heart. You should be knowing what is happening with your heart, what is your functional capacity, what is your ECG, what is your 2D echocardiogram, your heart's pumping, your cholesterol level, your blood pressure, your blood sugar. These numbers should be available to you. You should be knowing those numbers because when they deviate, you will be knowing that only when you measure them. When they deviate, they'll not immediately give you any alarm or symptom. When you get the alarm or symptom, then it's quite late. So first is know your heart, know your numbers. The second message is go to a person, a doctor whom you trust, but then trust them. This is a very important point because we have seen many people who are out of their mistrust, changing the treatment locations, changing the doctors, but never relying on any of them. Ultimately, the problem is with their treatment. They cannot get the best of treatment on time. So trusting somebody from the healthcare, trusting some hospital or trusting some doctor is very important on the patient's point of view. Then only they will get the best treatment on time. We have many times seen people not receiving best treatment just because of the doubts and mistrusts. So you select your doctor, then trust them fully. That is the second message.
Thank you, Dr. Vishal. Thank you for joining us and taking the time out to join the program.
Thank you.